also the rear or posterior third of the tongue. It's also going to be playing a role in some of the muscles that are involved with things like swallowing, etc. Okay? So clinical testing would include things like a gag or swallowing reflex is checked. The subject is asked to speak and cough. All right? And the posterior third of the tongue may be tested for taste. The taste sensation neurons and structures there. Receptors, I should say. Excuse me. Number 10 is vagus nerve. Now, the vagus nerve is extremely critical. It comes out, and if you notice, it comes out around where the medulla oblongata is. And this is a very important parasympathetic nerve, but because it also innervates not only, again, you've got the carotid sinus, it also branches off into a ganglion that eventually branches off for the heart, lungs, spleen, kidney. It also has branches that will go to the lower part of the small intestine and the beginning of the large intestine, otherwise known as the colon. It innervates also the stomach, gallbladder, and the liver. Now, you're sitting there saying, well, why? When we get into the parasympathetic response in Chapter 14, you're going to know the parasympathetic is more rest and digest. Okay? Also, what's happening is this is mixed nerve, clearly, because it's going to have motor fibers for the parasympathetic afferents, but it's also going to have sensory impulses coming in for the thoracic, the abdominal viscera, the aortic arch baroreceptors, so it's going to tell about blood pressure, the chemoreceptors that are in the carotid and the aortic bodies. This is going to tell you about oxygen levels, pH levels, things like that. And it's also going to have some information from the taste buds of the posterior tongue and pharynx. It will carry also proprioceptive receptors from muscles of the larynx and the pharynx, basically giving you feedback. Is the muscles taut enough? Should they be constricted more? How do we work this out in coordination of swallowing and things like that? Accessory nerve is unusual because the accessory nerve this is one that they kind of had a debate. Where does it really emerge? Is it really to be considered a cranial or not? It comes out somewhat in the upper cervical region of the spinal cord. It innervates the sternocleidomastoid muscle. It innervates also the trapezius muscle. And so what you've got is, although it's mixed, it's primarily motor. The sensory part is more proprioception of impulses from those same muscles, giving you feedback, okay? And this is something where they would do clinical testing and just asked for a person to rotate their head, shrug their shoulders against resistance, things like that, for clinical testing. Now, the last one, hypoglossal. Hypo means under, so this is going to be under the tongue. Yes, hypoglossal nerves. Basically what you're looking at is they are going to innervate the anterior or the front part of the tongue, controlling extrinsic muscles of the tongue, as well as taking some of the sensory information. It's going to be important in chewing, processing, and swallowing and speech. It is going to be also important in how you protrude and retract the tongue, and that's why they have it as testing. But it's going to be important primarily for the sense in being able to really manipulate the mouth in such a way for speech, for food mixing and manipulation, and for the start of swallowing. Okay? All right. Except for the vagus nerve, you want to keep this in mind. The cranial nerves serve only head and neck structures. Now what we're going to do is we're going to move into basically the spinal nerves. Okay? Now, the spinal nerves, what you have to keep in mind is you have 31 pairs of spinal nerves. Spinal nerves are named according to their point of issue from the spinal cord. Cervical starts with the letter C, and you have C1 through C8. Thoracic start with T, you have T1 through T12. Lumbar, of course, starts with L. It goes L1 through L5. Now, even though the sacral bones are fused, they have openings, okay, foramen to allow the sacral nerves to come out. Sacral are always designated with S, and so it would be S1 to S5. Now, the coccygeal gets a little confusing for some people, so they always put it down as CO, and there's only one, okay? Now, you've got to get used to a couple of terms here. Plexus or plexi. These are branches. Remember that they can spread apart, come back together again, and spread apart again. You've got a cervical plexus, a brachial plexus. You have also where you see where the lumbar enlargement is, go below that, and there you have the lumbar plexus and the sacral plexus. Okay? What are they going to be doing? Because a lot of these plexi are going to eventually serve the upper and the lower limbs respectively. Cervical brachial will serve the upper limb, lumbar and sacral the lower limb. You will also notice there, just to bring up a couple of points, you will have a lot of intercostal nerves. Those are going to serve in the thoracic region. And we're going to get into this a little bit more, but if you remember, we talked about the presence of muscles, the external intercostals, the internal intercostals. Well, they help innervate and play a role in breathing and respiration. Although the main muscle is the diaphragm, the intercostals will assist in chest expansion, thoracic expansion, and contraction. Moving on, we got to get used to the branches. The branches exist exterior to the spinal foramen. Ramus or rami is a term used as a branch, and they divide, and each is a mixed nerve. So the rami communicantes contain autonomic nerve fibers, and you can see those in this diagram here. You'll see the little branches coming in and out, and they're coming through basically the pathway of the sympathetic trunk ganglion. This is getting you prepared for more of the sympathetic autonomic nervous system that'll be played out in detail on chapter 14. Note the arrangement of the spinal cord. Note, again, gray matter, white matter, ventral root, dorsal root. Remember, the dorsal root's bringing in sensory information. Ventral root is sending out motor information, okay? Now, as I mentioned before, the intercostals are innervating between the ribs and serve the cutaneous branch sensory. We're going to get into that in a minute. I'm going to, and you're going to see in the handout, I give you a certain number of nerves. In this chapter, they go over a bunch of the sensory peripheral nerves. Well, they're not just sensory, they can be motor. I'm only going to give you a certain number that you have to know. But if it's on my notes, it's fair game for exams. So you need to know what they are, where they are, and what are they functioning, okay? So if you see it there, and I put down even in some situations, capitalized, learn, you need to do it. Okay? So let's move forward here. And as you can see here, this is a cross-section of the spinal cord pulling away, and you can see this cross-section here where you have some of the innervation of the dorsal ramus, the ventral ramus, the rami communicantes, the sympathetic trunk ganglion. And you see that in relationship to the spinal cord, the vertebra, and now you see the intercostal nerve. And notice how it basically branches off to the lateral cutaneous and to the anterior cutaneous. What you have to understand, this is part of how this spinal nerve works. And what you really have in the ventral rami from T1 to T12 is this intercostal arrangement, which we're going to find out is part and parcel of Hilton's law. Now, Hilton said that any nerve serving a muscle producing movement at a joint also innervates the joint itself and the skin over the joint. If you take a look very carefully, there is a subtlety here, but you can see it very clearly. You might not think, well, wait a minute, the rib's not a joint. Yeah, that's true, but then again, it does move between, the ribs move between muscles. And if you notice, the lateral cutaneous passes through the 2 layers of intercostal muscles and then innervates the surface skin there. And part of the end of the anterior cutaneous does the very same thing. Look near where the sternum is, okay? Okay. What we're going to do now is move through the branches of the various sections of the nerves. The ones I tell you that you need to know, you need to know. Okay? Lots of charts here, lots of tables, but just follow through with me here. And we're going to go through just the ones that are absolutely necessary at this time. The phrenic nerve, of course, controls the diaphragm muscle. That's breathing. You see the cervical pattern here on figure 13.9. Okay? You'll notice how some of the branches spread out and how they come together and then spread out again. Phrenic nerve is absolutely essential. If you remember a while back, I said what happens when someone is hung. You know, the thing is that if you damage the phrenic nerve, you pretty much have ended the person's life. It is breaking away the control from the brain of the neural pathways to those respiratory muscles, and that's what usually ends the life of someone. In the upper limb, you're going to have the brachial plexus, which leads to the following nerves. You need to know them: the radial, the musculocutaneous, the medial, and the ulnar. Now, part of this is also important. I want to give this some perspective here. You know, like all the television programs where the hero gets shot in the shoulder and it's like, oh yeah, I'll be better in a few weeks. It is not an innocuous injury. What you have in the shoulder, okay, is a lot of nerves and a lot of blood vessels. And yes, there's muscle and there's bone. If you have a bullet go through that, it may sever these nerves. And that may mean more than just a few days in the hospital and a big bandage. And anybody that says otherwise is really kidding themselves. It is a very serious trauma, depending on where and what passes through and what damages such pathways as medial. For example, if you cut at the medial, downstream you're going to lose all the pathways and all the neural connections there for ulnar and the medial cutaneous nerves for the arm, the forearm, etc. You cut or damage even higher up near the nerves of the subscapular or the dorsal scapular nerve or the nerve to the subscapularis. You've got greater damage downstream, okay, down the arm. And I hope that makes it a little clearer. So you need to know these nerves, and that's in the brachial plexus. You can see some of this in a cadaver image where these branches continue to branch off into smaller nerves, but even those nerves are going to be innervating large muscles to allow for the movement of the upper arm, forearm, and eventually bringing in sensory information from the arms and the hand. Okay? And you can see this here. So basically, really get down this. Now, some of you might be saying, well, does that mean you're going to show on an exam a diagram? No, maybe not. What I may do, though, is I might have a multiple choice question that talks about what is connected to what and what passes nearby. Now, ulnar and the radial nerve, etc., remember that there is this repetition that occurs in the name. If you've got a name that says radial, it may be involving